Hello, everyone. Good morning, good afternoon, and thank you very much for joining us here today. We have a very interesting lesson, percutaneous coronary intervention of aorto ostial lesion by Dr. Jegan. Dr. Jegan, thank you very much for presenting this lesson for us, and it's an honor to have you here. Please.
Good morning, all. Thank you for the opportunity. So myself, Dr. Jegan, I'm going to present percutaneous coronary intervention of aorto ostial lesions. Since the time given is only 10 minutes, so I have made it very short. I'll try to do my best. So this is an introduction slide, sort of a disclaimer, because I'm first going to start with a case in which I failed in aorto ostial stenting. So the case summary is a 60-year-old gentleman who was a diabetic, presented with history of hypertension of 1 month duration. ECG was normal, and echo showed normal LV function, no regional wall motion abnormalities. And this is the angiogram. So diagnostic angiogram showing, actually you could see only the left main and lady, there is no left circumflex. So there is no filling also retrograde. So we don't know whether it has an anomalous origin or nothing. So this is the right side coronary diagnostic angiogram. Here we can see definitely the circumflex is filling, and we can see it's coming all the way to the right cusp. So if you notice here in this place near the origin of right coronary artery, so basically it's an anomalous origin of anomalous origin of left circumflex artery from the right sinus. So then after trying some time, we just found the blunt stump here. So this is the stump of the LCX. It is arising below the origin of right coronary artery. So then we proceeded with PCI to the same, and the support was not good from the radial axis, so we had to take femoral axis, and this is Amplat's right one guide catheter, and it was wired with Fielder XTA, and then changed over to a cyan blue wire and pre-dilated. It was not very hard. Basically, it was like a subtotal occlusion. It was not like a proper CTO. And then after pre-dilatation, then we put a 3O by 48 millimeter stent. So this is the stent positioning video. So we can see. So we were thinking like we got the ostium.
So why did you use such a long stent?
Because we were not very sure of the anatomy. So actually I missed some videos because it was looking like multiple lesions query. So we thought we would cover it anyway.
Okay, so can you show the basal angiogram so we can see it more clearly? I didn't see the other lesions.
So this one.
So, okay, so here it's not very clear. So what can you do in this case? What would you do in this case to have a, higher quality of angiogram? Because here, if you only have this angiogram, you cannot say, okay, this is a lesion, this is so long, this is so critical. So what would you suggest to do? Okay, you have a fellow. So the fellow does this angiography. You say it's not, the quality is not enough. So I need to understand it better. So what would you suggest to him?
So here basically it's occluded, so we can see the so there is no antegrade filling, so it's only the retrograde filling, and we are seeing this. So after wiring and
yeah,
we can
one thing is that you put the guiding catheter, you put the wire, and then you can decide if to use. If it's not enough, you can decide to use a guide extension. Okay. But you need to improve the quality of the angiogram. Also before, because I'm not really sure that you should say, okay, I put a longer stent because I didn't see very clearly the angiogram. So this is not the way to go, in my opinion. So you should always have clear angiograms, or you do, as I said, you can use a guide extension, you can use intravascular imaging with IVUS, whatever. But before deciding the therapeutic for the patient, that's the most important thing. So you are putting something that the patient will always remain, okay? So this is my point. So you have to be sure that you are putting the best tool. So
But
doing an angioplasty, doing an angioplasty is, it's a very delicate moment, and your decision that sometimes, not in this case, but sometimes is taken in 3 minutes, will rest for the rest of the life of your patient. So this is what I'm saying.
But do you have, did you record the angio when the wire was in the vessel, and maybe it is...
Yeah, I have not put in the presentation. I have it here, actually. Yeah.
Okay. Okay, this was just my point. So please, go ahead.
Yeah. So this is post-stenting, and then we started post-dilatation. So actually, we started from distal to proximal. Actually, when we tried to position the proximal, we took a stent boost. Only then we realized, actually, I missed one point. So we lost the wire after we stented, unfortunately, because the patient took a deep breath and we lost the wire. Then we rewired, and the post-dilatation balloon was 3.5 by 12. It went in easily, so we were sure that it is not going through the struts, because we thought if it's gone through the struts, then we might feel some resistance. So it went easily. So we post-dilated from distal to proximal. Then when we are trying to position the balloon, then we realized that we had gone through the struts. We are not in true. So here we can see this has gone through this.
Yeah, this is a nice picture. Yeah.
So till then we were completely unaware that we are actually gone through the struts, and because the false assurance was given by the NC balloon, 3.5 NC balloon going smoothly without any resistance. So we thought, well, we were in the true. So then we realized that actually there is too much of stent actually protruding into the aorta. Then we went back, and then we saw our stent positioning, and then post-stent pictures. Then we realized actually this is the stent positioning. So here we can see it's not protruding much into the aortic root, but post-stenting, I'm not sure whether it's very clear, whether you're able to see, but we can see actually it had moved. So
you mean that you had a dislodgement of the stent?
Yeah, it's maybe due to movement of the many patient taking deep breath sort of thing. That's the only explanation, because we didn't move. So that's the point here. So then we tried many times to get into this, and unfortunately we couldn't get into the proper strut. So actually we thought whether we should crush this and then put another overlapping stent.
So wait a second. So I'm asking to anybody. So what would you do? You have this picture on the left. Okay, so you have a guide wire which is passing within the stent because you had to rewire. That can happen. So what would you do here in order to avoid crushing a stent, which is not a nice thing to do unless you're forced?
It depends how much back you've come into the aorta, I guess. If you sort of 3-4 millimeters back, then it's a bit tricky. But if one thing you can do is remove the balloon, back the guide out a bit, and then try and see if you can, rewire, and then pass an IVUS down and make sure you're sort of intraluminal. It's tricky because this one there's quite a bit of stent that looks like
another thing is that you can just push the wire. Well, you are here. Okay, you are here on the left. You push the wire, you get the catheter a little bit out, and then you try to rewire with another wire. With that,
so the other thing I've done is something similar, and then use a supercross angled microcatheter. So you kind of float the guide back out, with the wire in position, then use a super cross and kind of aim it 90 degrees,
Yeah.
and then wire it. So that's what I've done previously.
That's a good idea, but that's you are rich because you live in Singapore, so you can spend $1,000 more. So that's a good suggestion as well. Another one could be a more invasive one, could be to take a second access, a second guiding catheter. You leave that there, and you take another catheter with maybe another tip, because this is a little bit straight. I forgot what the type of the catheter you used, but a more maneuverable catheter, like an Amplatz curve, some Amplatz, 0.75, 0.10, whatever, and try to re-engage that.
Yeah,
But
so
you have several options.
Yeah, so unfortunately, we don't have that angle microcatheters in India when I was working in this hospital. And also we had taken femoral access actually, because initially we did the diagnostic angiogram through the radial access, and then this was femoral access. And we tried to wire this multiple times. Actually, we couldn't. So the idea of crushing was not safe and ideal. So as suggested by professor, so we didn't crush this. Actually, so this is the actually final angiogram. So though we had to accept this, and the patient is under clinical follow-up. He's doing well. He completed 12 months follow-up. So, so we had to end this case, and we had to accept this protrusion.
Yeah. So thank you. Can you come back to the first slide, your first slide? So the left system. Because I was walking and so I didn't have the chance of visualizing it. So yeah, so there is also this lesion.
Yeah, this one we fixed. Yeah, this one we fixed in the same setting. Yeah, we put 3O by 38 stent in this across the diagonal. Provisional, we didn't do anything for the diagonal. Afterwards, the diagonal was flowing.
This is an ostial. It's not the left main because you have the circ from the other side. So this is a proximal LAD. So just for my curiosity, I agree with the indication of doing angioplasty, but did you discuss this patient with a cardiac surgeon? Because this is like a left main, distal left main lesion.
Diabetic also. Yeah, we gave him the option, but patient didn't want CABG.
Okay, got it. Thank you.
So now going to the theory part of it. So aorto ostial lesions. Definition is more than 50% stenosis within 3 millimeters of the orifice of right coronary artery or left main coronary artery. It's more commonly seen in right coronary artery. The pathology, it's more rich in fibrocellular and sclerotic fragments. The lipid components are relatively infrequent. They are more rigid and calcific, difficult to treat. So isolated aorto ostial lesions, the underlying etiology could be inflammatory and non-inflammatory aortic wall disease. The risk factors being prior mediastinal radiation or prior aortic valve surgery. Sometimes we see external compression by a dilated pulmonary artery. So this cartoon depicts the unique funnel-shaped morphology and the angle of takeoff from the aorta. Actually, it's not actually everything. It's not actually in this single plane. Usually, it's a three-dimensional structure and funnel-shaped. It's not like this actually. So the diagnosis is many times missed on coronary angiography because we engage the ostium and only the soft marker is when there is damping, then we realize, and there is no contrast backflow, then we think there is potential ostial lesions. IVUS is actually very helpful in detailing the anatomy, and CT coronary angiogram also will help us. So the unique complications and challenges with aortic ostial stenting or stent dislodgement and stent embolization, and because of the calcium in the ostium, it may prevent the complete stent expansion and also longitudinal stent deformation and guide catheter or balloon induced dissection of the coronary artery, ostium, and aortic root. So how do we accurately implant the stent? So optimal aorto ostial lesion stenting requires, so we have to cover the entire circumference of the proximal stentage with the aorto ostial landing zone. So the geographic mix is diagnosed when there is at least a segment of the circumference is missed, either proximal or distal. So this diagram shows the optimal. So here we are covering the both. Hello.
Yeah, please go ahead.
So this shows this is optimal. So we are covering the ostium, and this is partial distal miss. So we are not covering the distal portion, and this is total distal miss. So we are completely missed the ostium, and this is too much. This is protrusion. When this protruding beyond the ostium, this is termed as partial proximal miss, and this is too much protrusion has happened with my case. So that was a total proximal miss. So this is a paper from Rubinstein et al. So actually he analyzed the aortic lesion stentings with CTCA. Actually by procedural, only with the angiogram, the position was satisfactory in 95% of the cases, but when CTCA analyzed it retrospectively, so there was geographic miss in almost 90%, so it was 87% geographic miss was noted. So among the geographic miss, 60% were anatomical misses, and 40% was procedure-dependent misses. So these findings highlight the limitations of conventional 2D angiogram, because the ostium is really the three-dimensional structure and its final shape, it's not in one plane. So even though it feels we have caught the ostium, so many times we actually miss the ostium. So this table column summarizes the challenges and the strategies which we can use. So for better visualization of the aorto-ostial plane, we can use IVUS and CT coronary angiogram, especially in case of CTOs. And there is a special device known as Ostial Pro, which will help us in exactly landing in the ostial zone. And
yeah, wait a second. So I agree with you that ostial lesions are very important because they usually subtend a large quantity of myocardium. So prognostically, they are important. Often they are important lesions. And I also agree with your message that they are tricky for the treatment. The only thing, yeah, I agree that we should do something more. Usually angio alone is not enough. So CT scan is important, but CT scan, let's keep in mind that when will only allow us to understand the anatomy and to plan the intervention, but cannot guide us during the intervention. So we can some images before, but usually the motility of the heart render it a little bit different from what the CT scan is telling us. So CT scan is important, but intravascular imaging, IVUS during the intervention sometimes can be more important, because you can do it, you can redo it if you have that. And so on. Yeah.
Agreed, sir. So the next challenge is the catheter instability. So as happened in our case, like initially we thought we are at the ostium, but finally when we had missed the ostium and there is a proximal miss. So to overcome that, there are various techniques described. One is called the Sabo technique. I'll show the pictures in the next slide, and the other technique is floating wire technique, and even Ostial Pro, it's helpful in stabilizing the stent also, and modified Sabo technique. Another thing is what can we do with regards to stent design. So actually the ostium is not really a cylindrical or tubular structure, it's actually funnel shape. So there is something known as ostial flash balloon, so which can make the stent way approximate to the funnel shaped ostium. So this is the Sabo technique, which was described many years ago. So in this, the proximal portion of the stent is actually released from the balloon, and then the coronary wire is passed through one of its struts, and then it's again crimped back, and then it is deployed. But there are some complications also. The stent may get dislodged, and it's not even 100% foolproof. And this is a floating wire. This is basically we just pass one more wire parallel to it, and we presume it opposes to the coronary ostium, but this may not be accurate, because we are not sure whether it's really opposed to the ostium, and it may be floating just. So we may just think anywhere the ostium may be here, or here at various points. And this is the Ostial Pro. This is a special device. In this, there is a radio opaque markers, and So this comes and attaches to the ostium, and then the stent is deployed. So this is
I've never seen it. Who is the distributor of this device?
Is Merit. Even I have not used it. This is not available. So when I was going through a review article, I came through, and it's from Merit Medical Systems, US.
Okay.
I'm not sure anyone used it. I'm not sure.
I don't know. Bharat, did you use it? You have weird things in your cath lab.
No, I've never seen it. I do live IVUS guided stenting. So on the floating wire, I park my Boston IVUS and leave it in place, and then I bring the stent until I see the transition zone between the balloon marker and the metal. And when you do it enough, you can actually see, and you land it exactly. You land the metal. So the balloon marker, you see it just outside the ostium, and the metal starts just at the ostium. So it's been quite precise. I've done about 11 cases, and the post IVUS is quite nice, actually.
This is this is another interesting technique. Thank you for sharing this. Please bear in mind that not all stents are the same.
Yeah.
Okay. In terms of distance between the balloon marker and the start of the stent, there can be big differences. For example, one stent, one interesting stent is the, don't know if you know, the Create. Now the last version is Create Evo. So that stent has a marker proximally that is angiographically visible, and you can use it angiographically as a marker. But that said, many stents have almost, not a millimeter, but almost a millimeter between the end of the balloon and the start of the stent. The last Zions family, they reduced this distance. So you are pretty sure that the distance between the balloon, the proximal or distal marker of the balloon, and the start or finish of the stent are really close. Whereas other earlier generation stents, like if I remember well, Onyx, they have a much larger distance. So just you to know, keep in mind this.
Yeah, very important. Very important. Zions is good because it's mid marker, so it's so when you place it, you're quite confident. And Create is nice. The platinum markers make it quite good to place. You're right.
So this is
all right.
So this is one more novel technique in Aorto ostial stenting described by Kate a couple of years ago, published in JACC intervention. So basically, this is like something like a modified Sabo technique. In Sabo technique, we just pass through the only on one side of the proximal stud. So what he did was basically the same technique. You uncover the stent proximal studs, and you make a loop for around 1.5 centimeters. So make a like J-tip, and then push it into the Y connector. So basically it looks like this when the stent is fully expanded. So this is outside. So here we can see it forms like a loop around the ostium. So it conforms to the plane, and then this marks the ostium. There are various other techniques being described. Some people use snare, and then they push the snare, and then it marks the ostium. So, but as mentioned by Dr. Bharat, the use of IVUS is much useful, and we can be sure and accurate. So the future is maybe incorporation of IVUS. These are future thoughts. Maybe on the stent delivery system may solve the issues instead of using one more separate catheter. Maybe I don't know whether this will come a reality, and something like a interprocedural three-dimensional imaging amalgamation using computer software, which they are using now in EVAR. But I do acknowledge that heart is like moving, and I'm not sure whether it will be like useful in coronary intervention. We do have it in aneurysm repass. They integrate the CT imaging with the fluoro imaging, and it helps them in guiding the intervention. But I'm not sure how feasible it will be in coronary intervention for using it.
All right.
Yeah. Thank you, everyone.
All right. Thank you. Thank you, Jegan. Thank you for this nice presentation and case sharing. Any comment or question?
I think it's
Jegan?
it's quite tricky. The aorta ostium is really I think if you look at it histologically, it's quite different from the rest of the coronary. So there is more fibrous tissue usually, and so preparation
Yes.
sometimes can be more difficult.
Exactly.
And you might need to use cutting balloon and scoring
Exactly.
balloon, and especially if you're planning on DCB as well. Preparation is crucial. And it can recoil quite a bit as well. So I don't know, Prof, your experience, prior to DCB, I find especially this RCA ostium to prepare it enough so you don't get much recoil, but obviously not dissect and cause problems.
Yeah, it's. I agree with you. It's a very tricky lesion setting. It's similar to the ostium of the circ. You have these fibers that go into the media. There is a lower component of muscle and a higher component of fibers, and these fibers are made of elastin, and they are more prone to recoil. And this is a big issue, as you said. So I tend to use more and more cutting balloon to prepare this lesion well. Cutting balloon actually was created for dealing with atherosclerotic plaque and moderately calcific. They claim highly calcific, but now we know that high calcification should be managed differently. So, but not for this type of lesions. However, I still think that a single balloon inflation, specifically if you want to go for a DCB, is not enough to prevent acute recoil. So using a cutting balloon is a good technique, in my opinion.
Thank you. Yeah.
So,
all right, guys, I have the
question?
patient on the table, so I must leave you. But it would be nice if you go on discussing for the next 30 minutes, if you have time. But Sarah is managing this, so if I go out, I should not leave you outside of the room. So when do we have the next lesson?
Beginning of September.
Okay, so we go
3rd of September. Yes.
Oh, that's bad. So yeah, I think that we should do another meeting for making the point about the scientific activities, because it's a bit that we don't discuss about that. So I would like to make the point with you, to listen to you if you have proposals and all of that. So I will write in the chat so we can decide when it is the best moment for all of us. Okay.
Yes. Thank you very much.
Okay. So please go on and have a nice day, you all.
Yeah.
Thank you. Thank you very much.
Thank you very
Bye.
much.
You too. Bye.
Ciao. Thank you.
Thank you, Dr. Jegan, for this very nice presentation. I'm asking other fellows if there are questions, comments. Please share with us, Dr. Wojciech, Dr. Filippo, Dr. Sylvia.
Yeah.
So I would like to thank you and congratulate. Very nice presentation. And one important point from my side is that we have some additional techniques like a Chabot. However, I think, in my opinion, we should use the safest technique like a wire in the aorta, or as the Barat manage the IVUS guided ostial lesion PCI, and those kind of procedure, PCI procedure, in my opinion, are the safest procedure, and for sure the safer than the Chabot technique when we put the wire through the first strand of the stent, and this is my comments.
Yeah. Yeah. Thank you.
Hello. May I ask one question?
Yeah.
How do you manage like the floating kind of a stent, like when there is too much movement of the stent? at the time of deployment. Especially it's common with the ostial lesions, like because our like guiding catheter is outside and the stent moves a lot, like with respiration, with heartbeat also it moves a lot. How do you like solve this problem? Hello.
No, it isn't. It is it is not so easy situation when the stent movement in the ostial, and where we want to implant very carefully in the and very we want to implant the stent in the ostial and to cover all of the vessel. In my opinion, the wire technique, and when we put the wire technique to the aorta, and but also important point is to push the wire to the aorta, not 30 millimeters of the wire, but deeper, and
Yes, yes.
and put the catheter very close the ostium of the lesion. So this is my point. I don't have any other idea.
Yeah.
Dr. Bharat,
Yeah.
maybe.
It's it's a good point. One thing I always tell the patient is, don't take deep breaths. So I always warn them, nice and shallow breathing. Obviously, as a sick patient, it's a bit different. But I always tell the patient, please don't take deep breaths, take nice shallow breathing. Putting the aorta ostial wire or sepal wire does tend to anchor. Having a third wire as a buddy wire sometimes can be useful as well. So, you got one wire down the left main to LAD or down the RCA, you put a second wire there. Sometimes that can anchor your guide a little bit, but it is tricky. Yeah. So like what Sheikh said, once you put the anchor wire and push your guide in, then the guide tends to sit up against that wire. And you want to put enough of the wire, not just a few millimeters, because that's all going to be the soft part. So you want the harder part of the wire kind of around the ostium and around the aorta, and the soft part kind of floating in the sort of proximal ascending aorta, just so you have that kind of anchor. And then you push your guide up against the, so you pull your stent back, push your guide forward, and your guide will hit the aorto-ostial wire, but not go in, and then your stent you're pulling back to kind of line it up. That seems to work the best, particularly for left main. I think that works quite well.
And
Yeah.
And as we discussed in some lessons before, that we should perform the post dilatation firstly at the proximal part of the stent. When we implant the stent, first we should do and when we are particularly when we are doing the ostial lesion, firstly we should post dilatate of the proximal part of the stent, and later to the distal part of the stent.
Yeah, very good point. Yeah, so you don't get that elongation of the stent.
Yeah.
So you do the proximal part, then you fix it, then you can move distally. Yeah, very good point.
So,
Yeah, thank you.
may I ask, Dr. Bharat, so you mentioned use IVAS. So which French guiding catheters accommodate all these things, like 7 French?
Yeah. Yeah, so that's a good question. So it depends which IVAS machine you use. I use the Boston Opticross.
Okay.
Yeah, so that's you need a 7 French system, and it can't be a EBU or a JL. You need if you're doing the left main, for example, you need sorry, it can't be an XB or a JL. You need a EBU. Just because the inner diameter is a little bit bigger.
Okay.
For the right, a JR4 is okay, but 7 French. You can't use 6 French. Yeah, it won't fit in a 6 French. But one thing you can do actually, if you do have a 6 French, is you put your IVAS, you go live IVAS mode. Don't do the pullback. You manually pull it back until you see the ostium, and then you cine there, like you store that, and then you know exactly on the fluoro where it lines up on the IVAS where your ostium is. So then later on, you make sure that when you're placing then you move that image across, and then when you're placing your stent, you use that stored image of the IVUS sensor tip and kind of line up your stent at that. So that's kind of another way of doing sort of IVUS guided, but it's not live IVUS guided. So you've marked the ostium with your IVUS, both on the IVUS and fluoroscopically, and then you use that to kind of land your stent.
Okay, thank you.
I just wanted to ask, like in this IVUS guided stenting, the IVUS is on the floating wire, like.
Yeah. So the IVUS has to be on the floating wire. And what you do is you move it, so you park it in place, kind of just distal to the ostium. Then you move it manually with the sled. So you don't have to pull the actual IVUS. You just move it with the sled. And remember, the sled comes backwards and forwards without moving the position of the IVUS on the actual wire, right? Because it's within the sleeve. So it will move on the sled forward and backwards. So then you can look at position by just moving it on the sled once you parked it in position. But it's on the floating wire, yes.
Okay, thank you.
Maybe try it for like, if you really want to try, before you try something difficult, you can try it on for example, an ostial LAD or a circ OM or something like that, another bifurcation. So you get the technique and you know what to visualize. And then different stents, like I said, the transition point between the radio opaque marker and the actual stent, it varies. And you just need to train your eye to see what the marker looks like on IVUS, which is a black kind of semicircle, compared to the stent, which is a shiny bit that will come into your frame of view. So it's quite nice. It's quite a nice technique. Some of our friends from Hong Kong have just published in Jack about it, so I can send you the paper. It's quite a nice read.
Yeah, I think it will be very helpful in diagonal and OM branches. Like we don't want anything protruding in the main vessel. Like ostial is still okay, like protrusion is okay.
Yeah, so I mean, technically, with the aorta ostial, if you have 1 to 1 millimeter, 1.5 millimeter protrusion, is not too bad. But for example, the LAD circ, and you're wanting to land at the ostial LAD, it's really nice for the ostial LAD. Like that's a very nice technique. It's very reproducible, and you really nail the ostium. You can see how nice, and you can actually see the stent end in the POC, which is really nice. I mean, whether that translates to outcomes, I don't know. But what I've noticed is, since I've done that, when I've had to do, like, for example, a STEMI case where I want to nail the ostium, my eyes have kind of become in tune now with where I think the ostium will be based on angiographic, because I've done the live IVUS. So I kind of know where I want to place it, and then you place it, and then you do the IVUS post, and you realize, hey, I've actually gone, very close to where I wanted it to go, even without live IVUS. So it's a nice kind of technique to do, because it trains your eyes a bit more also.
So
yes.
Just for my learning, so the case which I showed, which there was too much proximal protrusion. So at this stage, what you would have done, basically, we tried multiple times on without the angle supercross, and because only with that stent boost, it was very clear that it has that much protrusion. If you see fluoroscopically and angiogram wise, then it was not evident until we took that stent boost with that balloon in place. So when we see with angiogram, it was not at all looking like it's protruding, because only with stent boost it's very clear, and that much, like maybe it was protruding like 3-4 millimeters into the aorta. So
yeah, it's tricky when you have that much protrusion. Check, what would you do in this situation?
But just from my my experience, I feel that even if it is protruding into the aorta, a lot of times nothing happens actually. Means initially, during initial years, a lot of times I had this problem, like stent was protruding in aorta, and most of them are doing good. Like nothing will happen.
Yeah, I
Physically.
agree. But the only thing is when they require re-intervention, it becomes a problem really. That's when
Yes, yes. Reintervention becomes problem, and many times what you can do is you can go by the side studs actually instead of going
yeah.
from the ostium.
So that what. So it's like going to the side straight and crushing and then trying to cover it with another stent. Is it safe or I have not seen that, but I have heard from people saying like you could have crushed it. So when I showed them this, they said you should have just taken a balloon and crushed it and then put one more stent and covered it till the ostium.
Depends actually. Dr. Bharat can tell us.
Yeah, it's tricky. I mean, even if you rewire through the ostium, if you've got 4 millimeters out, then to post dilate that, and you're kind of opposing against nothing. Whether that's actually, see, the balloons, they need to exert a force outwards and then have a counter force that's exerting upon them. If you're kind of floating, then I don't know what will happen to the stent if you try and just dilate it in kind of free floating aorta. I guess it would just be larger and it'll just hang there. Given you've rewired now and you've tried to rewire and you can't, maybe putting an IVUS down, seeing where you are in terms of in relation to the ostium. If there's a lot of gap to the ostium, then I would probably, because now your stent's going to be also, the other thing about the point that you've gone in is now you're going to get LSD there, right? You've guides banked it, your guides kind of impended on it. So you're going to get longitudinal stent deformation, and that's a risk factor for complications. So I would probably have passed an IVUS down, do the pullback, see where you are, how much is the distance to the true ostium from where you are, and then probably high pressure balloon inflation, kind of crush it, and then maybe put a short stent to kind of nail the ostium. Because one worry now is that your guides already banged it, so you've got LSD now. And like you said, for re-intervention in the future, it's going to be very challenging. So yeah, it's tricky. It's a tricky situation because now you've post dilated. I don't think you can snare it and pull it out.
Yeah, that was too long stent. Even we thought like, but that pulling out that long stent will make much problems. Yeah, that's why we didn't.
Yeah, so I don't think you can snare it and pull it out. So one thing you might have to do is, like you say, just kind of balloon dilate, open up that strut into that, and then kind of cover that with a short, high radial strength stent like Megatron or something. Kind of put it in the, maybe 1.5 mils out, and then flare the ostium a little bit. But yeah, it's a tricky one. What did you do in the end?
No, actually, we decided to follow the patient clinically and maybe required something like CT coronary angiogram later. So, but he's absolutely asymptomatic. He's just following up in the clinic, completed more than 2 years. So.
Yeah, so sometimes just long DAPT and hope for the best.
Yeah, he's still on DAPT.
Yeah, so this one maybe 3 years of DAPT. Yeah,
Yeah,
3
exactly.
years DAPT and then reassess. But yeah, interesting. So it's tricky, very tricky.
Another worry was like if we had to crush it and cover it with another stent, I'm thinking like whether we would injure the ostium aorta. Is there any chance for dissection because we are crushing 2 layers of stent and that metal getting pushed into the intima of that aortic root?
Yeah, not sure about what the impact is, but I think it will just flatten out against the sort of. This was coming off the right coronary cusp, isn't it? So it might just flatten out against the cusp, and hopefully not. I don't know. I don't know if there's very many case reports about this. Would have been a very nice case report.
Thank you.
Yes, thank you very much all for sharing these very nice points and discussing them. And if there are no more comments, maybe we conclude this session. And thank you very much, Dr. Jegan, for this very interesting session. And thank you all for being here.
Thank you, everyone. Bye.
Thank you very much, guys.
you.
Nice to
Thank you.
see you.
Bye-bye. Thank you.
Take care. Bye-bye. Ciao. Bye-bye.